Um, I'm Edoardo Za. Actually, I'm a cardiac surgery resident, but don't worry, I don't bite usually. Also because I'm also very deeply involved in structural intervention, and thank you so much for the opportunity to speak today. I don't have any disclosure. Maybe the only disclosure I can say is like I'm really a good friend of cardiologists, and I like to mess up their tables sometimes, and they're very, very kind with me. So I'm very pleased to show you this actually first in human case that we have done. This patient is 63 years old female that presented with COPD, severe dyslipidemia, severe also chronic kidney disease with the shunt in left arm, and it's going to be very important for later, and persistent heart fibrillation. The patient presented with severe dyspnea, lung murmurs, and severe heart failure decompensation. Regarding the risk assessment, the patient was in class NIA 3 in guideline medical therapy for heart failure with error score of 5.6 and TRI score of 8. About a bit of the cardiac history, it's important to say that the patient had a two vessel disease, one previously treated on the right, but most importantly, the severe TR that she had has been treated with the TTVR, specifically with the Evoque valve of 44 millimeters, and then later like a CRT implantation. Of course, echo is the first line of assessment. As you can see, the left ventricle was in a good shape, except for the dimension was slightly dilated, but with severe, moderate to severe aortic regurgitation with dysfunctional right ventricle. I also wanted to put there the Evoque implantation just to give an idea of the setting that you will see later. This is the CT, because I strongly believe that despite a patient go to surgery or transcatheter, patient with a aortic should get a CT, like with TAVI protocols. And so we had the valve assessment, as you can see, with the area and perimeter derived, but also on the other side with the also assessment of the anatomy. But I think the other point was the access assessment. As you can see, there are multiple things that we can point it out, which is the femoral artery was very narrow and calcified, but also the aorta per se and the subclavian. But we're gonna arrive there in a second. So what to do next? So just to summarize, we have decompensated aortic regurgitation patient with right ventricular dysfunction with the previous TTVR. On the other hand, we have a CT with periphery, which is calcified and calcified subclavian. On top of this, the high-risk patient with multiple comorbidities. I think that heart team in this place is really the most important device, if we want to call it in this way, that we have, that we can choose whether surgery or whether aortic regurgitation, but in this case with a dedicated device. And the idea was to go on with a Jena Valve implantation. As you can see, we already discussed before. I will not go along on this. The Jena Valve has 3 anchors that needs to get in the cusp of the valve to be implanted and then deployed. On the valve assessment, there is no more to say apart that we decided for a Jena 23, just based on the anatomy, but was not this the issue. I think the principal issue was the access. Just to give a brief idea on the possibility, the femoral, that how the Jena is designed was not possible because it was too narrow and honestly too calcified. We have the subclavian, but on the left we had the shunt, but also was calcified, so not feasible. And transcaval also in this case was not considered, as well as like the right was calcified. So where to go actually? And also in this case, I think the heart team, it's our precious thing that we can use, and the idea was to use a right carotid artery access that was actually isolated surgically. And this is also, I wanted to point it out on the right hand side, the hybrid setup, because of course you have, I don't know if I have the pointer, yes, here you can see the head of the patient and here the foot, and to give this curve of the valve because you need to go from above. I will show you also a video about this. And this is the sheet insertion and retraction, and it's very important how you can see from the fluoro, but also from outside, how surgically speaking, we are handling with the tourniquet, just not to make everything bloody. And this was the insertion from the floor. The next step is the position and release. As you know, at this point was not really different from a transfemoral, despite the trajectory. The important thing is to get the anchors in the cusp of the valve, and then after that the valve is deployed. The check with as you can see from the first one, for example, the check with the contrast to be sure that the anchor is on the leaflet is essential, of course. I wanted to put, and it was also in the title, the TTVR, that was a bit on the middle when in the different projection. I've choose for sure the best projection that we had, but in some others were a bit more challenging. This is the result. No paravalvular leak and no gradient, good result. Also, the patient was discharged after 5 days, and the follow-up at 3 months was remarkable. We checked also the access because, as you know, even though it was a surgical isolation, you never trust surgeons. So in this case, we decided also to check the access. So the take-home message, I think, is that AR, it's really a broad spectrum, but also now with transcatheter procedure, it's feasible. Despite also no access in this case, you can always find a way to Rome, I would say. And the hard team approach is really our best device that we can actually use. Thank you very much for your attention.